I once again take an opportunity to welcome our chairperson, Dr. Akshay Nair from Chembur. I hand over the session to Dr. Akshay Nair. Thank you so much for being a part of AIOC. We are glad to have you.
Thank you. That's very specific from Chembur. I'm from Mumbai. That should be enough. And thank you so much. We'll start. I'll just check with my co-speakers if we are all ready to go. Co-instructors, great. Dr. Savri, you're there? Oh, okay, good. So let me then introduce our wonderful panel. Our course is called Identifying the Wolf in Sheep's Clothing. This is basically a course designed to discuss topics that are at the conjunction of neuro-ophthalmology and oculoplastics, and also some tricky cases, conditions that overlap both these subspecialties. I am Akshay Nair. I'm an oculoplastic surgeon practicing in Mumbai. My co-instructors are Dr. Rashmin Gandhi, who's currently affiliated with Foresight Worldwide International and Center for Sight Hyderabad. He is a neuro-ophthalmologist who was trained and was a consultant at Shankar Nethralaya for over a decade and a half, following which he did a fellowship at Johns Hopkins University, and currently is the vice president of the Indian Neuro-Ophthalmological Society. He's been an educator who's spearheaded multiple training programs and examination training programs like the FRCS and the FICO on multiple conferences in India. Joining him is Dr. Savri Desai, who's one of the, as they say, OGs, the original people who started exclusive oculoplastic surgery practice in Mumbai. She's currently affiliated with the PD Hinduja Hospital, having been fellowship trained at L.V. Prasad Eye Institute, Hyderabad. Dr. Savri has been the organizer for multiple oculoplastic conferences at the national level over and over again, and we hope to see that leadership when the annual conference of Oculoplastics Association of India comes to Mumbai next year again. Joining them is Dr. Tarjini Dave, who's currently the Associate Director of the CAR campus of L.V. Prasad Eye Institute in Hyderabad. She's also a consultant in the Oculoplastics and Ocular Oncology department, and her areas of interest include thyroid eye disease and mucormycosis. And she's taken the subspecialty or the niche area of orbital and socket reconstructive surgery to a next level. Incidentally, this was an instruction course that was submitted last year, and the topic that Tarjini was, happily took was thyroid eye disease and infiltrative sinus fungal disease. Little did we know then that would be such an important topic in the months to come. Without further ado, I'd stop my screen share and invite Dr. Savri Desai to share her screen and begin our takeoff into the session.
Thank you, Akshay. Can you hear me?
Yes, we can.
Okay, so I'm just going to share.
Before we start, the audiovisual people, Tanvi, if there is an attendee by the name of Dr. Mohsen Khandelwal, who comes
yes, we do have the
video.
video.
Yeah,
yes,
we have the video, but he say he may join in. So if he does join in, please make him a panelist from the
okay,
attendees.
Sure.
So much.
Yeah.
Thank you, Akshay, for that nice introduction. And we're hoping that everybody from Bombay, there's so many of us all participate in the upcoming Oculoplasty OPI conference. So, basically, we're going to be talking about ptosis evaluation, back to basics. But when Akshay asked me to speak, he said that it comes with something like, the red flags. So I found it really interesting because this is a topic that you present right from your early days of post-fellowship to now. And I actually thought that this was such a, specific way to actually present it and point out the things that really matter. So what is a red flag? A red flag is basically defined as either a danger signal or a warning, but it can also mean that it alerts you to something and not necessarily can be a danger or warning leading to something bad, but it can be a prior alert. And often we flag our males just to let us know that this is not dangerous, but it's important. So evaluation of ptosis has all these, lists of the routine, what we go through. And this is the laundry list of how we evaluate it. We have a chart, we mark out all these, stick out all this. This is how we teach our residents. And while we'll be going through each of these, what we'll be really looking for is that what are the red flags that we really need to point out in these. So let's come to something very basic. Is there ptosis really? So let's look at these two patients. The patient on top complained of a left eye ptosis, while the patient, the lady below, complained of a right eye ptosis. And they're absolutely right in what they're saying, that one eye looks smaller. So the simplest thing that we always tell or talk about is that look at both the eyes together and see that there's nothing else happening in the other eye. So obviously in this patient, she has a contralateral eyelid retraction. Many other causes which cause there's bulging of the eyeballs in cases like ophthalmos, in myopia, which will make the eye appear bigger and give rise to a pseudotosis. While in this case, the patient may appear that she has a ptosis, but in fact it is a ipsilateral enophthalmos. That means the same eye has is looking ptotic because of the enophthalmos. Similarly, this gentleman here complained of a drooping gradually over time. But if you look closely, yes, he does. I mean, when you compare it and you do an MRD, but when you just lift the brow, you see that there is basically a brow ptosis with a severe dermatochalasis, which is giving rise to a pseudotosis. So basically, these are all pseudotosis. And while they're not red flags, you don't want to rush into surgery and have something else land up happening. The other thing that, which I've not put a photo, is that also to look as the face in toto, because often you will find, and I'll come to a photo later, where a patients actually have a facial asymmetry, which is already known. Now, if you look at this girl, she said that she had a ptosis in the right eye, and she actually does have a ptosis of about 1 millimeter and almost touching 1.5 millimeters. But she also has certain other things. So she's not a pseudotosis, she has a ptosis. But when you point it out to her, she has a lateral droop, she has a mild brow ptosis. And if you see the upper tarsal show, which is a really important marker, which we often talk about in, not related to ptosis, but in thyroid eye disease, I think it's a good marker to see. You will see that her upper tarsal show in the ptotic eye has been always lesser right since her childhood photos. So history plays a big role, and it's not, while it's not a red flag, it's something you can go back and review. When you look at this girl, she complains of a right eye ptosis. She does have a right eye ptosis, but on history, which she gave later because she was keen on having a repeat surgery, she had already had a prior 2 surgeries to correct it. So someone like this is definitely a red flag. 2 prior surgeries with a relatively good correction, and she did have some amount of facial asymmetry, is definitely someone I would be wary about treating for a 3rd surgery to give something beyond this. So of course you have the palpable fissure height, up gaze, primary gaze, down gaze. This is something that's taught standard to us, and marginal reflex distance. But there is a purpose to each of these gazes. So let's come to those. So of course, one is you look at all the gazes, you make an MRD, and you basically classify mild, moderate, and severe ptosis. But what if we just break it up? So what does it really signify? Primary gaze is severity of ptosis, and up and down gaze gives us an indication of a levator action, and the down gaze gives us indication of a lid lag. So here's a small video to just show how you test for LPS action. So this is a severe ptosis. You see that you put a thumb on the frontalis so as to eradicate the frontalis action, and ask the person to look from down to up. Now, while you're looking this, in this simple action, you can find many things. So what is a lid lag? So lid lag is nothing but a delay in the eyelid movement while looking down. But when you measure it as a static sign. And you can see that there is a difference in the same child, and there is a significant lid lag. What does this indicate? This indicates usually a dystrophic levator muscle and is often seen in congenital ptosis, not in aponeurotic ptosis. And the degree of the levator lid lag determines what? It determines often the kind of surgery we do and the kind of counseling we give to the patient, because this is something that will not go away. And it is a question that is asked recurrently by the patients. Will this go away? And it does not. It is important to notice the lid lag. And in this is the patient post-surgery of mine with this moderate onset ptosis, and you can see that the lid lag has worsened. So lid lag is often definitely a very important red flag, which should be noted. Similarly, coming to lag of thymos, this patient had a moderate to severe ptosis. This is the inability for the eyes to close. So why does it matter? So as you can see, she had a very, very minimal lid lag. But this is important as in cases of congenital ptosis, and when you're doing a levator resection, just like the lid lag, the lag of thymos will worsen significantly post-surgery, will reduce over time, but may still remain. This is important as if there is a very severe lag of thymos or moderate to severe, you want to be sure that you give good topical lubricants and also counsel the patient that there will be a worsening. Coming to margin crease distance, we measure it while we are looking from down to up when the lid crease starts forming, and the importance is it gives us an indication whether it's congenital or acquired as an aponeurotic ptosis. It gives us an indication of the levator action, and of course, it's a surgical line. Now, I couldn't find a good photograph, but the real red flag is, in this cases, is when you have multiple lid creases, which is your surgical line or line of fire that you would choose. So probably it's always measured to the opposite eyelid, but you want to, so even in this girl, there are few multiple lid creases. You will obviously take the measurement to the right side and match it here. But in case it's a millimeter here, often either above or lower, you will still take one which is closest to the normal eyelid. Extraocular movements is something that we all check, and you know that there is congenital ptosis, which is associated with superior rectus elevation paresis, and also there is complicated congenital ptosis. But as you can see in this patient, and this was a photograph I borrowed from my fellowship days because I didn't have one of my own, is that you can also have a double elevator palsy. And this is really important to note down. So extraocular muscles and the movements and its association with any restriction or a syndrome is extremely important. Even in cases of ptosis with hypotropia is very important, as when the hypotropic eye is made to look in primary gaze, often the ptosis goes away. For whom the Bell's toll. So Bell's phenomena, as we know, is when you ask the patient to close the eye and there is an upward and outward protective movement of the eyeball. But why is this actually a red flag? That is because when you correct a ptosis, you want to have a good Bell's phenomena, especially in congenital cases. Because if the Bell's is not good, you can lead to severe corneal exposure. But let's think of some other case scenarios that you may see. There is something called as a reverse phenomena, in which basically it goes downwards and outwards, an inverse, which is upwards and inverse, and a perverse, where it is in all directions. These are the ones to be really careful about and note, because a Bell's phenomena, which is moderate or poor, can still have a good outcome. But in these cases, the cornea can get fired and you could be in trouble. Coming to synchynated ptosis, Marcus-Gunn ptosis is something that most of us see and in our, in our training, and we know the beauty of how on moving the jaw, because of a synkynetic innervation, the eyelid goes up. Now I'll come back to this case later to point out the red flag, but let's go to the next thing. So basically there's an opening or a widening of the ptosis. The ptosis basically increases on movements of the jaw. And this is just something I put because often people don't know that you can actually grade Marcus-Gunn, and mild is when it elevates 2 millimeters above the ptotic lid or goes up to the limbus. Moderate is when you go up to a little bit of scleral show, and severe is when it elevates to 4 millimeters above and there is a significant amount of scleral show. Back to this boy, the red flag here is that basically he has a well-formed lid crease prior to the ptosis correction. Now, in this case, on measuring it, his ptosis action was just 6 to 7 millimeters. But because of the well-formed lid crease, you often feel, though you know the muscle is dystrophic, that you think that the levator will do well even on a moderate to advanced levator resection. But this is a red flag because of the synkinetic. Often these patients do have a well-formed lid crease and they still have a dystrophic levator and need to be like a maximal levator resection to really get a good correction. Others will end up with a really, really poor undercorrection. Coming to this last patient. So here is a girl. So parents were very happy because they thought that while they had noticed something, they felt that most of the times I looked symmetrical. But then we found that she often dropped her lid, which led to meridional amblyopia because of a refractive error. So in synkinetic ptosis, it is important to notice the time and the amount that they are being able to hold the eyelid up, because otherwise it can lead to lazy eye or amblyopia. So this is her post correction with a sling. Now coming to Herrings Law. Herrings Law is basically when the eyes are, when there is a ptotic eyelid, and thank you Akshay for lending me these photos at the nth minute. But the basic principle is that when there is a ptotic eyelid and you lift the other eyelid, if you lift the ptotic eyelid and the normal eyelid drops, this is known as Herrings Law. This occurs because there is a single simultaneous innervation occurring to both the levators at the same time. So when the eyelid is corrected, as is seen in this case, there is a drop and the patient often feels that something has been done while you have corrected the ptotic eyelid, something has been done and ptosis has worsened. And this Herrings Law is extremely important and is a red flag and needs to be informed to the patient prior and shown, because the correction needs to be titrated accordingly. Finally, coming to Schirmer's and the cornea. Schirmer's is an extremely important test, especially in adults, because while in children, the cornea adapts quite easily, in adults, often it can lead to dryness and exposure. And finally, this is my last slide. And oh, sorry, I'm just going to play this. This is a patient, if you can see, he was a patient of mine who came with bilateral eyelid retraction and then started complaining of ptosis and was advised surgery. But if you see, on exertion, eventually the eyelid starts coming down. So always be careful before you plan a surgery. This was a patient who developed a myasthenia. So it is very important to test for, even when rule out neurological causes. And with that, I'll summarize that a red flag is nothing but knowing the variations in the presentation of ptosis. Documentation is a must, and patient counseling is probably the most important thing. With that last slide, I give it to you, Akshay, to take the next topic. Thank you.
Thank you so much. I think you've covered it comprehensively and above all in time. So I think as per our order, I will share my screen now and start presenting. My screen is visible now, right?
Yes, Akshay.
So I'm going to talk about myasthenia, primarily the investigations and how do you work up a patient and what are the unusual presentations that we need to be wary of. So like we said, like Savi said, you know, the one theme that all of these speakers will be touching upon is red flags, because that's what we need to pick out. Cases that look simple, but could be sinister. So myasthenia, we know, is an autoimmune disease that affects a neuromuscular junction. The cause for ptosis here is because the muscle, which is supposed to lift the eyelid, which is the levator, has an issue with the neuromuscular junction between the branch of the third nerve that gives the motor supply to the levator muscle at the neuromuscular junction, there are antibodies that are against the anti-acetylcholine receptor. Now, we need to know that there is now growing evidence that to suggest that myasthenia, while it is a single spectrum, there are different endpoints on it, and ocular myasthenia and generalized myasthenia are, although connected on the same spectrum, there are a lot of patients who are seen to have exclusive myasthenia, ocular myasthenia gravis, and may not progress to systemic myasthenia gravis also, which normally is the rule. But one thing is that unilateral ptosis is the most common presenting sign in ocular myasthenia gravis. Now, there are four main diagnostic and clinical tests that we employ to diagnose or conclusively rule in or a diagnosis of myasthenia. These are ICE test, neostigmine test, anti-acetylcholine receptor antibodies, and electromyography or single fiber EMG. So as a rule, you should always check for myasthenia in all ptosis patients. By doing so, you will be able to pick out that rare case that comes, the wolf that wears the sheep's clothing. So one thing is a history of variability. Something that you need to know is that it's not always as per the book, which says diurnal variation, which means evening worsening of the disease, which means in the morning it's good, but in the evening it worsens. People's schedules are now different. People are, have lesser sleep pattern, different sleep patterns with less sleep at night, and it doesn't always follow the rule of it's better in the morning, worse in the evening. It can even be the other way. So if there is a history of variability, that should be enough, and don't always look for worsening in the evening. Ocular motility has to be checked every time. And if the patient complains of occasional diplopia, sometimes I see double vision, on few days I've seen double, but now I don't, that should be a red flag again. Different diagnosis previously. Someone else has diagnosed him as something else previously, and someone has diagnosed, you see the patient, and now a patient has been previously diagnosed as a lateral rectal palsy, but now the patient only has ptosis. That should be something that should worry. No diagnostic pattern. You see a restrictive, strabismus, but it doesn't fit into an A pattern, a V pattern, a DVD. It's something unusual. It doesn't fit into a third nerve, a sixth nerve. Atypical presentations. Ask for systemic history. If a patient oftentimes needs water to swallow morsels of food, that could be a sign that generalized myasthenia is already set in. Other things where they could complain of tiredness is walking, and while chewing, they need to take breaks between morsels. So age no bar. This is a 2-year-old girl who came with left eye ptosis. The parents, said that she's sleepy all the time, and she came with both the parents. She was diagnosed as congenital ptosis elsewhere and was advised of sling surgery. And then I asked her, we always ask for a history of to rule out myasthenia. And surprisingly, the father said the left eye is always droopy. The mother was categorical in saying, no, the right eye is also droopy. Both eyes are droopy. It's just that now you see the right eye looks a little normal. So I asked them to get some blood tests done, including the antibodies, and come back a week later. And a week later, you can see both eyes are total. So antibodies were positive, and the child also had a thymoma. Now, this is another patient, a 73-year-old male, who had a history of trauma on one side of the head. And the CT scan showed an undisplaced lateral wall of fracture, and visual acuity was 20/80, which could be attributable to cataract. There was ptosis. The patient complained of diplopia since the time of the trauma. And the patient had been diagnosed as traumatic optic neuropathy and a traumatic third nerve palsy, and was asked to observe. And the patient sought a second opinion. But if you look at the 9-gaze pics, this doesn't look like third nerve palsy because there is restriction, limitation in all gazes. The sixth nerve is partially limited. The medial adduction is partially limited. So this doesn't fit into a pattern. All we did was an ICE test. And when you check for motility, and I'll come to that a little later, you place the ice pack for 3 to 5 minutes, and the motility had improved completely. So sometimes you can have different presentations. ICE test has a very high sensitivity and specificity. You need to know that majority of the patients with ocular myasthenia gravis that present with ptosis will almost always have a positive ICE test. I'll quickly run through a short video on how to do the ICE test. So before you start the ice pack test, you need to document the patient's photograph and take measurements of the eyelid. So here you can see that the right eye has moderate ptosis, the left eye has severe ptosis. And then you place the ice pack on both the eyes, because as you can see, the ptosis is in both eyes. Now, two things you need to know. You do not keep the ice pack for longer than 2 minutes, because keeping it for longer than 2 minutes inhibits the natural contractility of the muscle. So even though you may have got a positive ice test at 2 minutes, but you've kept it for longer, so you may end up getting a false negative ice pack test. So keep it only for 2 minutes. You can keep it for a slightly longer period if you want to check for ocular motility. But for ptosis alone, 2 minutes should be good enough. Now, after 2 minutes, you take the ice packs off. And again, you need to take a photograph, document, and measure. And then you have a clear comparison in front of you. And you know that the ptosis has improved from 3 millimeters in the photograph above, which is before, to 8 millimeters in the photograph below, which is after. So you've got, after keeping an ice pack for 2 minutes, you've got a minimum of a 2 mm improvement, which is very, very typical of a positive ice test. And this is your minimum requirement for a positive ice test. Sometimes you may be on the fence, and those are what we call equivocal ice tests. Now, another test that you can also do to check for myasthenia is ask the patient to look up. And asking the patient to look up in sustained up gaze induces what is called fatigability. Like Dr. Savri did in that patient, you can ask the patient to look in all gazes, or particularly keep looking upwards. And you will see that the ability of the patient to retain the eyelid in that position gradually worsens, and till a point that the patient is unable to keep his eye open. And this is classic fatigability, very, very pathognomonic of myasthenia. The other test that can be done is neostigmine test, but this is an invasive test. It has to be done in the operating room with an anesthetist on standby. It has a very high sensitivity, but most of the evidence that we have for the sensitivity of neostigmine test is from generalized myasthenia. Nothing is there for ocular myasthenia. Single fiber EMG, it's the most sensitive test for detecting abnormal neuromuscular transmission. Basically, the most sensitive test to detect any pathology in the neuromuscular junction. It has a high sensitivity in generalized myasthenia gravis, but when you use the frontalis or the orbicularis, it has a limited sensitivity in ocular myasthenia gravis, mainly because ocular myasthenia gravis affects the extraocular muscles and the levator, where it is not easy to introduce electrodes and check for single fiber EMG. The other thing is anti-acetylcholine receptor antibodies. This is a gold standard, which means if you have a positive antibodies test, there is no ambiguity about whether the patient has myasthenia or not. Only thing is that while generalized myasthenic patients may have 80 to 90% of these patients may have the antibodies, a significantly lesser proportion of ocular myasthenia patients have positive antibodies. So there is a lot of variety of testing and varying sensitivity. So we've come up with a nomogram to figure out which test needs to be done when we talk about myasthenia. So these are the different tests. And to understand what it is, so ice test or sleep test have moderate sensitivity and high specificity for myasthenia. Fatigue test, like I mentioned, is highly specific. Antibodies is moderately sensitive but highly specific. And this similar, you have these parameters for repetitive nerve stimulation, EMG, and heterophony. So in ocular myasthenia, what we've done is a study that we conducted. 37 patients of myasthenia who presented as unilateral ptosis were subjected to the 4 tests, which is single fiber EMG, acetylcholine antibodies, ice test, and neostigmine test. Ice test was seen positive in 34 out of 37 patients. Neostigmine test was seen positive in 21 out of 37 patients. Single fiber EMG was seen in 22 out of 37, and antibodies were seen in only 17 out of 37 patients. So in terms of the positive values, you can see the order was ice test, single fiber EMG, neostigmine, and antibodies. But if in this cohort, the average age was about 46. So we split the group into 2, below 46 or below 45 and above 45. And single fiber EMG was significantly higher in patients who were older than 45. So if you have a myasthenic suspect who is above 45, there's a good chance you may want to do single fiber EMG along with an ICE test rather than antibodies in order to get a higher diagnostic yield. And then the mean duration of symptoms in our group was 13 months. So we split it into two groups, less than 12 months symptoms and symptoms for more than 12 months. And here what we saw that patients who have longer disease tend to have positive outcome in neostigmine and antibodies. So age of the patient and duration are parameters that you may want to think about before ordering which investigation. Same is the case for diplopia. If the patient has had a history of diplopia, then single fiber EMG again gives a higher positivity rate. So because this has a lot of economic implications in a country like India. When you do the complete battery of tests, you are almost subjecting the patient to what is equivalent to the cost of a surgery. So you may want to not do a laundry list of tests and cherry pick which ones you want to do. So ICE test has the maximum diagnostic yield in predictive myasthenia across all ages, except in severe ptosis. In those with a history of ptosis for more than 12 months, antibodies and neostigmine may be useful. In patients older than 45 years and those with a history of diplopia, single fiber EMG tends to give higher positivity or diagnostic yield. And in patients with severe ptosis, your initial investigation should be an acetylcholine receptor antibodies. So these factors of age, duration of symptom, and history of diplopia should be there in your mind. Now, what is the association of thymoma with myasthenia gravis? So if you see, more thymoma patients more generalized myasthenia patients have thymoma. So 14 to 22%, almost 1/4 of generalized myasthenics may have a thymoma, and less than 10% of ocular myasthenia gravis patients may have a thymoma. But remember, ocular myasthenia gravis can always progress to generalized myasthenia gravis, and the thymoma may be present even before generalized myasthenia gravis sets in. So you should always remember that thymoma is basically almost like a paraneoplastic syndrome that is seen in myasthenia gravis. Antibodies should be checked, and if the patient has antibodies, you may want to do a CT scan imaging to make sure that there is no thymoma. This is, I think, a little complex beyond the age or beyond the scope of our treatment of this presentation here. When I talk about therapy, I've limited my therapy only to one slide, mainly because I firmly believe while we can start medication, the follow-up and monitoring of myasthenia therapy has to be done in conjunction with a neurologist. Remember, neurologist is also a physician, and they are equipped to handle the side effects which medications of myasthenia can have. The first line is acetylcholinesterase receptors, which is pyridoxine, pyridostigmine, and along with that, we give a short course of corticosteroids, which may have to be extended. Remember, corticosteroids gives a favorable response in almost 85% of ocular myasthenia patients. Although complete remission is rare with corticosteroids alone, which is why it is combined with acetylcholine esterase inhibitors and maybe immunomodulators. Why do you want to start treatment early? Because steroid early in ocular myasthenia gravis can reduce the likelihood of progression to generalized myasthenia gravis. And it also reduces the proportion of patients who progress from ocular to generalized myasthenia gravis. There was a study that showed 36 to 83% of patients with ocular myasthenia gravis progressed to generalized myasthenia gravis when they were not given steroids, but only 7 to 17% of patients who received early corticosteroid therapy progressed to generalized myasthenia gravis. So without prednisolone, generalized myasthenia develops in up to 50% of ocular myasthenia gravis patients within 1 year. And finally, if you don't get a good response or suboptimal response, you may want to switch over to immunomodulators. So what have we learned? We've learned that there is no one single test to rule out myasthenia. Investigations can rule in or diagnose myasthenia, but a negative investigation or a negative clinical test doesn't rule out myasthenia. Ptosis and diplopia are the initial signs of the disease in over 50% of myasthenia patients, and up to 80% of these patients, if left untreated, can go on to develop generalized myasthenia. And in majority of the patients, progressing to myasthenia, for ocular to generalized myasthenia will occur within the first 2 years after ocular symptoms begin if they are not treated. Early steroids may decrease progression. Gold standard is anti-acetylcholine receptor antibodies. If you have the antibodies, you have myasthenia. And in some cases where you don't have antibodies, but still the ptosis persists, response to therapy may be considered as a diagnostic sign of myasthenia gravis. CT chest should be done in all adults who present with myasthenia gravis who are test positive for antibodies while being investigated for myasthenia gravis. I think this is the same kid slide we already saw. And now I'm going to invite Dr. Rashmin Gandhi to share his screen. Dr. Gandhi is going to tell us about pupil palsies and ptosis, neuroophthalmic pitfalls for the oculoplastic surgeon.
Thank you so much, Akshay. Thank you for inviting me for this instruction course. I've just simplified the title to Neurological Aspects of Ptosis, and a part of it has been covered beautifully well by Savri and Akshay. So why it is important to look at a neurological aspect of ptosis. As was mentioned, most of these conditions which can come to you with ptosis, and ptosis as the only sign, are progressive. And if you miss any of those conditions, and if you go ahead and operate, you may end up in a problem. As you see in this young man who presented with ptosis, he was found to have a probable progressive muscle problem. We were not very sure of the diagnosis. Went somewhere else, got operated, and this is a post-operative picture. Down below, you find that ptosis, in fact, has increased a little bit, and now he has a little eye in the downward position because of the surgery. So it's very important that we make sure that any progressive condition, most of it in neurological region, they are ruled out before we embark on surgery. And what are we really looking at? We are looking at nerve problems. It can be a third nerve which supplies the LPS muscle and can come to us with ptosis. In third nerve, because of the fellow travelers, we are not really worried about diagnostic dilemmas, but we are then worried about how do we progress further. The other nerve issues which can present to us with ptosis would be Horner syndrome, and I'll be covering both by an example of a case. Myopathies and myasthenia, as was covered beautifully by Akshay. So let's look at this patient. This is a 65-year-old gentleman who comes to you with complete ptosis. He has a vasculopathic risk factors, and as you see, there is a complete ptosis. The eye is exotropic, and when the patient looks to his left, there is limitation of adduction. The abduction is normal. When the patient looks up, there is limitation of elevation, and he looks down, there is limitation of depression. And as you can probably see, the fourth nerve is functioning. There is a torsion of the eye when the patient looks from up to down. And it's not very clear here, but the pupil was of normal size. So here is a 65-year-old gentleman with a complete ptosis, no other cranial nerves involved, and the pupil is normal. What should we do next? Well, by the textbook thinking, we'll say that this is a classical case of third nerve palsy because of ischemia or ischemic third nerve palsy. And we can observe the patient, and these are likely to improve. 90 to 92% of these patients where third nerve palsy because of ischemia would improve between 3 to 4 months' time. Let's look at a few examples before we come back to this thought process. Now, this is a lady who was told that she has RAPD and that she has a ptosis. You can see that there is a ptosis of the right eye, and I will be checking optometrically using the torch just to highlight one of the important signs that one should look at when you are examining a patient with a third nerve palsy. The patient looks to the left. The adduction seems to be fine. The abduction of the right eye is fine. But as you notice here, the right pupil is larger than the left pupil. So there is a ptosis with anisocoria. And you'll find here that elevation is depressed, and there was a mild limitation of depression as well. So here now we are dealing with a partial third nerve palsy with involvement of people. Obviously, the management is going to be different. These are the patients who require an urgent neuroimaging. And we'll see one more example before we discuss as to what kind of neuroimaging and when. This is the other example where you again should look at your threshold for neuroimaging should be very low. Is this the patient who, as you see here, there is a ptosis? She had a third nerve palsy around 3 months ago. She came back saying there is a remarkable improvement, but just the ptosis which is persisting. Let's see here what happens when the patient looks to the left. Look at the eyelid of the left eye very carefully, and you'll find here patient is adducting. Adduction seems to have come back fine as well. Patient looks up and you say that elevation is not fully improved. But what I want you to see is a sign of aberrant regeneration, but there is a clear lid lag and a complete disappearance of ptosis when the patient looks down, which is one of the signs of aberrant regeneration. There are 3 signs of aberrant regenerations clinically that you should be on the lookout for every patient of third nerve palsy which improves. One, when the patient looks down, there can be a lid lag. It is also called a pseudo-1 Ruffle sign. When the patient adducts, there will be widening of the palpebral fissure. That's also called inverse Duane syndrome. And when the patient adducts, there can be constriction of the pupil. That's sometimes called Zernike's sign. So these are the 3 signs of aberrant regeneration which you should be on the lookout for when there is a third nerve palsy which has resolved. Now, why I'm emphasizing on the aberrant regeneration, because you have to remember that aberrant regeneration is almost never seen in ischemic third nerve palsy. So if you find a patient with aberrant regeneration and you find that patient has not been investigated, that patient surely is a candidate for further investigation. So let's, third nerve palsy, look for anisocoria, look for larger pupil, look for aberrant regeneration, and look for involvement of other nerves, especially the 4th and the 5th nerve. Look for corneal sensation, look for intorsion in a down gaze to see whether 4th nerve is involved or not involved. Now, why we are harping on this? Because one of the important causes of a third nerve palsy is aneurysm of posterior communicating artery. Now, 86% of the patients who harbor aneurysm would present with third nerve palsy with involvement of pupil, with larger pupil on the same side. So what it tells you is that 14% of the patients who are harboring aneurysm would still present to you with normal pupil. So these patients require, even if pupil is normal, according to a conventional older thought, these patients would require a continuous follow-up to see whether pupil is getting involved little later in the course of the disease. And why this is important? Because these aneurysms, especially these aneurysms which are not very large generally, 10% of these patients would die before medical attention because of subarachnoid hemorrhage. 50% of them, they die within 1 month. And the remainder will have residual permanent neurological deficit. So a patient who walked into your OPD would have a high chance of morbidity and mortality, and that's the reason why we are worried about a third nerve palsy. Now, this is 2002 enrollees recommendations, where he says that if there is a complete third nerve palsy, complete ophthalmoplegia, and pupil is spared, there is a lower risk and you can observe. Rest all carry a risk of patient having a compressive lesion of the third nerve, and the commonest compressive lesion would be aneurysm of PCOM. The new thinking has been, because there have been anecdotal reports of patients who present with complete ophthalmoplegia and pupil sparing in here, but also on neuroimaging because of some other reason were found to have a lesion which was responsible for third nerve palsy. And as I said, because what you can miss out if you don't do neuroimaging can be fatal or can have a massive morbidity for the patient, the newer thinking is that almost all third nerve palsy patients would require neuroimaging. Now, what neuroimaging that you are requesting for? MRI brain and orbit to begin with very low threshold for angiography. So you need to speak to your radiologist. If he finds a reason for third nerve palsy in MRI brain and orbit, then he does not need to do anything further. But in most instances, he will end up doing MRI with MRA. There has been a great debate between a merit of MRA versus CTA, but I personally do MRI with MRA and it will pick up most of these aneurysms. There have been practitioners who have a very low threshold for even advising conventional angiography because, as I said, because the disease that you're missing out can have a fatal consequences. So even if MRI is normal, but you have a strong suspicion, pupil is large, there is a partial thermal palsy, patient has pain, patient has a family history of aneurysm. These are the patients who might actually end up having conventional angiography, invasive angiography to see whether patient has aneurysm. So that's about the third no palsy. But this is the second patient who comes to you with acute onset of headache and neck pain. And must acknowledge Dr. Devendra, who shared this beautifully documented patient with me. You can see that there is a mild ptosis of the left side. And you look at the pupil, because one of the facets of the talk is the pupil. So you look at the pupil. Now, when you look at the pupil in this instance, you are actually worried about the efferent side of the pupil. So you want to see whether is there any anisocoria, number one, and number two, what happens to anisocoria in dim illumination and a bright illumination. And as you see here in dim illumination, this pupil is dilated, this pupil is not really dilated that much, and in a bright illumination, the pupils are of normal size. So in other words, the anisocoria is worse in a dim light, telling you that this patient has a sympathetic system problem of the left side, patient has a Horner syndrome. So what do we do next? Now, any residents in the audience would always come up with the answer saying, we would like to do cocaine test and hydroxyamphetamine test. Well, I will tell you that the access to cocaine has become disappointingly low. And that's the reason why these pharmacological tests have given up. You have to find out in an acute onset Horner syndrome, and these are some of the causes of acute onset Horner syndrome, why you're worried about an acute onset Horner syndrome, and why do you get ptosis? You get ptosis because of paralysis of Muller's muscle, which is responsible for 2 millimeters of excursion. So the ptosis generally is very mild. And if you have an anisocoria, acute onset, what you're worried about is dissecting carotid aneurysm. And this is a paper by Valerie Buse, beautiful paper, which said that 44% of these patients had dissection, and 32 out of 65 patients who had this dissection, actually Horner syndrome was the only sign of dissecting carotid aneurysm. So if you find mitosis, if you find a small pupil on the same side, you're probably dealing with a neurological problem. You're probably dealing with a serious neurological problem. So that patient needs an immediate referral. If you are going to manage it by yourself, patient, your area of interest is actually neck and chest. 78-year-old female with bilateral ptosis, and this is something which Akshay touched upon. You see, when you keep examining this patient has a ptosis and it will keep increasing as you examine. Another subtle sign which you should look at, which I found very useful, is that you find this lid fluttering. When you check the oculomotor, there can be mild flutter, which I feel is an extension of Kugan's lid twitch. And you find here, patient looks down for 15 seconds, makes an upward saccade, and there is a very impressive Kugan's lid twitch. These are the signs of ocular myasthenia. As Akshay mentioned, there is no single test which will give you a definitive diagnosis of pure ocular myasthenia. And you have to rely on these clinical signs like Kugan's lid twitch, lid flutter, fatigability, eyes test before you diagnose these patients. And you also have to remember that this looks very similar to myasthenia, but heteroremoval involution ptosis behaves very much like myasthenia as far as fatigability is concerned. So the index of suspicion in these patients before you operate should be high. 8-year-old female, unreliable history. She was posted for the operation of congenital ptosis, but you see clearly there is a presence of lid crease. Again, an index of suspicion should be high, and this patient actually was found to have ocular myasthenia. We switch tracks and see this patient, bilateral ptosis, symmetrical ptosis associated with complication of ocular motility. Patient is not able to look to the left, to the right, up and down. This was something which she developed around 3 or 4 years ago, and over a period of time, her condition worsened. Obviously, we are dealing with CPEO, or chronic progressive external ophthalmoplegia. There are two myopathies that you should be familiar with. CPEO, generally seen or onset is in younger age group females. You need to look at the fundus, rule out pigmented retinopathy. Also, refer these patients for cardiologist evaluation because they have higher association with a heart block, which again can be fatal. Myototic dystrophy, generally seen exactly opposite spectrum. Older age males would have an associated ocular features like pupillary abnormality, Christmas tree cataract, and even glaucoma. One of the important markers of myototic dystrophy is you shake hands with the patient, and because they have a problem with the calcium channel, you'll be able to shake hands, but you'll not be able to loosen the grip. That's one of the reasons why they develop ptosis as well. So that's about myopathy. Another important examination point, because we're dealing also with palsy, is the patient has complete ptosis. Let's see what happens when the patient is checked. Patient looking to the right, no abduction, no elevation, no depression, and no adduction. That means you are not dealing with third nerve palsy, but you have a third and a sixth nerve palsy. Patient's corneal sensation also was impaired on the same side, so probably looking at orbital lesion or a cavernous sinus lesion. Look at the optic nerve function test. If the optic nerve function test is fine, you're probably looking at superior orbital fissure or cavernous sinus. These patients will require MRI to make sure to rule out an inflammatory versus a compressive lesion. This is an interesting patient I wanted to show you. He came and said that when he reads for a longer period of time, his eyelid droops. Look at what happened. Just see the video carefully and see what happens. It's a little longer video. And as we were following up the patient, we actually knocked off the cataract. You see when the patient is trying to look to the right, up, down, the eye movements are very, very slow. His presenting problem was lid drooping after prolonged reading. And see what happens when we are examining the ocular motility, and suddenly you'll find that the eyelids were closed. And this is what his complaints were. And then he says that he has to do this, right eyelid opened up nicely. And then after some time, so he was told that he probably has myasthenia because prolonged reading, drooping, you can see a little ectropia as well. But he also had Parkinsonism, and these patients can have associated oculomotor or lid apraxia, and that's what this patient had. So in other words, all adult onset ptosis, always look for neurological aspect of ptosis. Third nerve and Horner syndrome are two things that you're looking at as far as the nerves are concerned. Myasthenia is neuromuscular junction, and myopathy is about the muscle. Look at the movement of the lid. That will give you a clue as to what's going on. Pupil, as part of the title as well, is extremely important. Any involvement of pupil, you're very sure that this is not congenital or involution ptosis. You're also sure that this is not like myasthenia, because myasthenia, pupil is never involved, and ocular motility, of course, will give you a clue. And what happens if you miss out on any of this? This is an unfortunate patient who underwent a surgery. You can see the ptosis scar here. And following this ptosis surgery, he developed this weird kind of ocular motility where eyes were not moving properly. So basically, he had some weird form of ocular myopathy, but he ended up blaming the surgeon. And he said that all this started after the ptosis surgery was done. And that's the importance of ruling out any of these mimickers of ptosis. Thank you, Akshay, and thank you for your patience.
Thank you, Dr. Ashwin. It's good to know that even an expert like you sometimes calls conditions as weird ocular motility, because sometimes these things just don't fit into what you know.
Yeah.
All right. We'll have a separate section to where we can discuss some cases as well. But for now, can I ask Dr. Tarjini? She's already shared her screen to continue with her presentation.
Thank you, Akshay. Thank you for having me on this course. It's been very nice to look at all the presentations that have been made until now, especially the videos. I thoroughly enjoyed Dr. Ashwin Gandhi's presentation. Am I clearly audible?
Yes, yes.
All right. So moving on to the last topic for this course, I'm going to talk to you about red flags in thyroid eye disease and invasive fungal sinusitis. I have no financial disclosures to make. You will see certain full face photographs of my patients for which we have the consents in place. So my objectives today are to take you through certain abnormal presentations in both thyroid eye disease as well as invasive fungal sinusitis. Look at certain confusing scans. There's a lot that has been spoken on ptosis, and I'm going to touch on it as well a little bit. Certain ophthalmoplegias that you see. Again, atypical scans in invasive fungal sinusitis, cutaneous fistulas, and finally summarize with the help of 10 interesting cases that I've tried to put up here. So the first one that Akshay wanted me to cover was thyroid eye disease, and you typically tend to associate eyelid retraction with thyroid eye disease and proptosis with thyroid eye disease. The retraction can either be the upper or the lower eyelid, and this is a patient, a series of photographs following treatment, which kind of shows you the natural history in a patient with thyroid eye disease, where they develop the inflammatory component. You treat them with steroids and at times immunomodulators or decompression to see a reduction in the amount of periorbital inflammation. However, there are certain patients that may present differently. So let's take a look at this gentleman. He came with this left eye proptosis. He had an inferior scleral show on both the sides, and it looks very much like a thyroid eye disease. He did not have any systemic thyroid dysfunction. His thyroid function tests were normal, but strangely, he had had multiple scans done previously, and every scan was reported as him having a left vascular malformation. So now, with this background knowledge, when I was shown the scan, to my mind as well, these kind of shadows in the orbit looked very suspicious. This is not how the classic fat stranding in thyroid eye disease looks. So it sort of set me thinking that, is this, it's in all the quadrants, it's intraconal, extraconal, ill-defined. Is this a form of lymphangioma which is restricted to, the posterior orbit and to the area just behind the eyeball? Even if you look at his muscle enlargement, it's not very classic of thyroid eye disease. So that set me thinking that, we need biopsy in this patient. And I thought in my mind that we do an open sclerotherapy where you enter the orbit, biopsy, as well as inject sclerosant into the vascular channels. That's what I did. However, histopathology only showed fibrofatty tissue. His entire collagen vascular profile and thyroid function tests were repeated, and they were again normal. And this is how he looked after the intervention that we performed with the residual proptosis. So I asked for another scan, and I saw these persistent orbital shadows there, and he was very bothered with the proptosis that he had and just did not want to have an eye that looked prominent like that. So considering that we could not figure out any sort of a lesion in the orbit, definitely not a malignant lesion, I thought that decompressing the orbit might not be a bad idea. Since we've definitely ruled out a malignancy, there's nothing that's going to go from the orbit outwards. And I performed a 4-wall orbital decompression for him, following which he remained stable with this kind of appearance for a period of 5 years after treatment, and never had any issues related to any vascular malformation. So that is the first case which I wanted to show you. And if I can just take you back to the original pictures, the image that he came with had CT scan with contrast. And we do not typically advise, contrast enhanced CT scans for a patient with thyroid eye disease. So it got me thinking, could it be just the diffuse fat stranding that we label on a scan? Does it look like this when you inject the patient with contrast? That remains to be answered. However, we proved with all the surgical means that he did not have any other lesion in the orbit, and he was never treated with steroids, and these lesions remained persistent over the next 5 years. So moving on to another set of cases. So essentially, I put up this collage here just to tell you that you'll have all sorts of eyelid retraction in thyroid eye disease. It could be your upper as well as lower eyelid, or just a subtle lower eyelid retraction, or a prominent lower eyelid retraction as you see in these patients. But retraction is one of the hallmarks of thyroid eye disease. So what do you do when you see ptosis? This is a lady who has bilateral proptosis. You can see that from the worm's view here. But along with that has this ptosis. So do you investigate a patient like this, or what do you do? There are several situations in thyroid eye disease where you will see associated ptosis. This lady just had an aponeurotic ptosis and essentially was not really bothered. So we did not offer any sort of surgical correction. But just to tell you that you can see ptosis in thyroid eye disease. These are her scans. Whenever you see ptosis, it's important that you work up and you definitely build up a diagnosis of corroborative diagnosis of thyroid eye disease associated with ptosis. And you can see in the coronal cuts, the thickened medial and the inferior rectus muscles, and this nice tendon sparing muscle enlargement on the medial recti on both the sides, which is very classic of thyroid eye disease. Since she was not interested in any intervention, we left her alone. Now look at this, another lady who is a known case of thyroid eye disease with right minimal proptosis compared to the left eye on the worm's view. A little bit of probable lateral flaring on either side. It's not very classic, but yes, a little bit of proptosis and a deranged systemic thyroid profile. So this was her. She had certain ocular surface related symptoms which were taken care of. And then 3 months later, she comes with this picture. So now she's developed ptosis, and that's her concern. Why are both my eyes looking smaller? And this is not what you classically see in a thyroid eye disease patient. So what do you do in such patients? You image them is one that we already spoke about earlier. And second, a lot has been spoken about myasthenia. You perform an ICE test for these patients and you see an improvement following ICE test. You can run the entire panel of myasthenia workup on these patients. But just to drive home the point that 5% of your thyroid eye disease patients can have associated myasthenia gravis. So when you see ptosis, we've established two things. One, image and look at the orbit, look at the apex. Second, you do a myasthenia profile to rule out whether the patient has coexistent myasthenia gravis. Now, this is another lady who has an inflammatory thyroid eye disease, and she's being treated with steroids. And this is post 3 days of treatment with steroids. She also has ocular surface issues on the right side related to exposure keratopathy. So after steroids, you're seeing a very suboptimal sort of response. And actually, there's a buildup in ptosis. There's a worsening. There's lid edema here, but no ptosis. There's still lid edema here, but now ptosis. So it's not just the mechanical component that can explain ptosis. So in such patients, even though your vision might be maintained, look for color vision and image the orbit to figure out if there's compression at the apex. Thyroid eye disease with compressive optic neuropathy can also present with ptosis, and that's what she had. And even though she was in the active phase of the disease, you see these muscles sort of squishing the optic nerve right at the apex. Coronal cuts would have been better, but unfortunately I don't have those. So she underwent an orbital decompression of the inferior wall and the medial wall, as you see over here, to sort of relieve that compression from the optic nerve and displace the muscles towards the sinuses so that the optic nerve has a breather. So 3 things we've established in ptosis when it is associated with thyroid eye disease. One is your run-of-the-mill aponeurotic ptosis can be associated with thyroid eye disease. The second one is compression at the apex. And the third one is associated myasthenia gravis. Now let's move on to a little bit on invasive fungal sinusitis. We've had a lot of discussion on muca. I'm going to show you certain other interesting cases as well. This introductory slide is just to sort of make you understand that this is how your typical bacterial sinusitis would look. You'll have the rubodolor, color pallor, loss of function, all of that, along with a scan which may show you certain abscesses and an associated sinusitis. This is typically your bacterial sinusitis. Now compare that to this patient who has this large abscess in the eyelid and associated even intracranial abscesses and a complete loss of your lateral wall and bony destruction that you see all around. When you see this sort of bony destruction, it's more likely to be fungal sinusitis. This is a very recent patient who presented to us with just a little bit of limitation in adduction. But he, if you look at the history that I've noted down here, he is a COVID recovered patient. He's very young, 27 years old, was never diabetic earlier, but due to the severity of SARS-CoV-2 infection, he was treated with steroids. And in 3 weeks after treatment, with steroids and complete recovery, he developed this sort of diplopia and restriction in adduction on the right side. So this patient had already undergone some amount of sinus debridement, and he had this orbital presentation here. The micro and histopathology from the sinus debridement, you see this black area here, which tells you that a large amount of sinuses have been removed, was suggestive of mucormycosis. So just to tell you that so much of orbital involvement in the inferomedial quadrant can present with an absolutely quiet eye and a little bit of nerve palsy and ptosis. So this is one of the red flags that we should all be aware of. Treatment wise, a lot has been spoken on mucor in a lot of courses at AIOS. I'm not going to get into the details, but essentially every patient gets systemic amphotericin B and sinus debridement, and a select patients require orbital interventions in form of debridement or transcutaneous retrobulbar amphotericin B or exenteration if the disease is severe. And then COVID positive or COVID negative status also sort of affects your decision paradigm. Now moving on to certain other cases. So this is a gentleman who complained of just a 2-day history of ear pain followed by this severe eyelid involvement in 2 days. Typically we know that fungal infections are indolent. They present after, they have a subacute course, but this is just a 2-day history. He is a known diabetic since 2 years, borderline control, no COVID history, and he presents with vision of PL positive and has a CRAO on fundus examination. And if you look at his clinical presentation and the scans, you realize that there is this necrosis of wide area of necrosis of the skin. This is abnormal. This is not common in bacterial fungal infections. And when you image him, you can see the ipsilateral side sinus is completely hazy. So this again is a pointer towards fungal infection of the orbit. And we performed his swabs, as well as he underwent an ENT procedure where he underwent FES is the wrong word, but he underwent an extensive debridement of the sinuses. And all of it, when subjected to histopathology and microbiology, came out as aspergillosis. And he was treated with amphotericin B and itraconazole for a long period of time. And this is him. You see that the lower eyelid abscess over a period of time has completely resolved with treatment. So this is one presentation. When you see a necrotic eyelid like that associated with orbital cellulitis picture, think fungal. One another lady here who complains of left sided, ocular surface symptoms, redness, watering, blurred vision since 15 days. She has an inability to close her eye, as you can see over here. She has had this abnormal appearance for over 10 years. And she now has the subcutaneous nodule, as you're able to see over here. So, so what do you do with her? Obviously, you need tissue diagnosis here, but before that, you'd go in for a scan. Now look at the bony orbit here. It is so abnormal. Look at the maxillary sinus, it's completely involved, and look at that thickening of the bony orbit. So it's not only bone destruction, but also hyperostosis, which can be a sign of fungal infections. We performed incisional biopsies from our nodules as well as from the bone, and it grew Aspergillus flavus. We could see it on the smear. It grew in culture, and the DNA was also positive on a PCR testing, which sort of leaves no doubt as far as the diagnosis is concerned. So she again had aspergillosis. Surface symptoms were taken care of by a tarsorrhaphy. The nodules were debulked. You really can't do much about the bone, but she was treated with ketoconazole for a period of 4 months and radiologically was stable at the end of treatment with no further worsening. So bone destruction, bone hyperostosis, skin necrosis, all signs of fungal disease. A couple of last slides. This is another gentleman here who presents with left total ophthalmoplegia and has this kind of discharging fistula that you're seeing superomedially. Again, a known diabetic, and has a long course of symptoms lasting for about a year, and also has vision loss. So a cutaneous fistula with a cellulitis-like picture, again, is very suggestive of fungal infections. On imaging, he had this apical involvement, and look at that destruction of the bone superotemporally. So destruction, and in the previous case, hyperostosis, both sort of point towards a fungal etiology. The last case here, this is pre-COVID era. If you look at the scans, they're 2002, who presents with total ophthalmoplegia, very minimal sinusitis, and you have this apical involvement, which in a known diabetic patient with deranged blood sugars. So in his case, again, to establish the diagnosis, we had to go in endonasal endoscopic and remove a bit of tissue from the orbital apex and subject it to microbiology and histopathology, both of which suggested fungal sinusitis. The reason I put this picture up is when you have apical involvement, you do not see sinusitis, do not start the patient right on steroids. It's important to get tissue diagnosis to rule out fungal infections, especially if you have host factors like diabetes and deranged blood sugars. So essentially, orbital fungal infections can masquerade inflammatory neoplastic vascular pathologies or nerve palsies, or it can look like your run-of-the-mill Tolosa hunt and have an apical presentation. But if you see an immunocompromised patient with ophthalmoplegia or subacute presentation that has bone destruction, hyperostosis, or these kind of cutaneous fistulas and skin necrosis that I showed you, suspect a fungal etiology and get a micro and histopath workup to back your diagnosis and treat the patient accordingly. Thank you so much. I hope I've finished on time.
There is no time restriction at all. We're well paced. Our session is slated to end at 7:55. But I think that was an absolute smorgasbord of beautiful cases with excellent documentation. I love how the recent mucormycosis wave has probably made you dig up all mucor cases, including that one gentleman who's got no nose, no sinus involvement, but has apical involvement, something that we realized towards the end of the wave that we are seeing.
It's retrospective wisdom now. Had I been shown that patient earlier, probably I wouldn't have thought on those lines. So,
agree.
Yeah.
Well, at least that's an important point, and I want to go to Dr. Rashmi. Have things changed in terms, now we know uveitis and neuro-ophthalmologists, they're in love with steroids, and you won't disagree. So, but has your threshold for steroids gone up a little more? Given that a lot of patients now have comorbidities which could, especially post-COVID, or you see optic neuritis and you still have the same threshold, you think it is clinically something that can be treated with steroids, you go ahead, or are you a little more cautious? Or basically, how has COVID and its manifestations affected neuro-ophthalmological use of steroids?
So there are two different aspects, right? Anywhere when you had a cavernous sinus or orbital inflammation, as Tarjini said, our threshold was always very high because of a couple of patients who went southward in Chennai when the steroids were given to take care of the inflammation, which looked like inflammation in the orbit and cavernous sinus, and actually it was fungal and it spread. Now, I had actually a dilemma when there was a peak of mucormycosis and COVID was going on. Patient had a loss of vision. Patient had an ocular motility problem. Ocular motility problem was partially explained by what he had in his brainstem. He had some thrombosis and ischemia because of COVID in the brainstem, COVID patient. And vision loss then, if you say ocular motility was because of that, vision loss can be attributed to optic neuritis, which is like now anti-MOG optic neuritis has become quite prevalent in patients who have COVID-19 infection. And those patients would require steroids because otherwise you might end up, if it's MOG or NMO, they might end up with paraplegia and they require urgent steroids. But now if you say brainstem lesion is not explaining ocular motility, there was something going on in the orbit as well and sinuses had some opacity. So then you say, oh, are you dealing with mucor and would you give steroids? Are you really making that patient? We actually, luckily, we didn't give steroids and the lesion spread, unluckily for patient, but actually he survived with the treatment with ENT. So yes, absolutely. We have to be extremely careful with steroids now. And we don't give steroids to everybody. Yeah, we do not.
Right. Sorry, before we go into that, I wanted to ask about one thing. Oftentimes you touched about it a little bit. how do you assess patients with multiple lid creases? Typically patients who have had long-standing aponeurotic ptosis or even some congenital ptosis, where you have 2 or 3 creases which are of equal prominence. I always find that to be a little tricky, because the last thing you want, you do a good ptosis correction, you get good contour and height, but you have an extra crease on top.
And then the patient is complaining only about the crease and not the height. I think when you ask the patient to look from down gaze to up gaze, the first crease that actually starts forming, which is very subtle, is probably the crease which is the most prominent crease to eventually form. So you have one crease which is, so basically there is either a double or a triple crease pattern which I've seen. One is where it is one lower crease and an upper crease, which is about 2 to 3 millimeters apart. And another one is where there is a lower crease, a very faint what appears to be a middle crease, and an upper crease. So I've always found that depending on the other side, I tend to take the lower crease only because my scar tends to ride up by about a millimeter. So based on your surgeries, by how much your scar is going to go up, because I tend to take a suture in such a way that I found that my surgical scar tends to go up a little bit. I always tend to go towards the lower side and choose that, or the one that tends to be a little more prominent on, when going from down to upper gaze. Because I feel the upper crease, if it goes further higher, then the upper tarsal show is what really bothers them. That's my experience.
Right. Tarjini, anything you want to add to that?
Yeah, Savri's covered it beautifully. So that's one thing that I follow as well. Additionally, if it's a unilateral case, then I look at the other eyelid and then I try to equalize the tarsal platform. So I look at how much is the distance between the lid margin and the skin crease on the normal side, and bring that onto the other side, and then see which of those double, triple creases falls, in that distance, and sort of try and equalize it.
Thank you. I think we've been informed that we need to play Dr. Mohsen Kashkoli's keynote address.
Okay, if there is time, Akshay, I want to ask Rashmin a question later. Okay, I mean, both of you, sure, if there is a time.
Yeah. Tanvi, you can play the pre-recorded video.
Yes, sure. AV team, can you just go forward with the video, please? Anup sir?
Madam.
Yes, they are preparing.
I enjoyed this course. This was the least hustled course with no time restriction.
Dear colleagues, dear chairs, I would like to thank All India Ophthalmological Society, especially Dr. Feroz, my dear friend, for the kind invitation. Here we are going to have a deeper look into the outcome of any ptosis surgery beyond the MRD1. No financial disclosure. Have a look at this picture. What we see is the eyelid ptosis mostly, and we do and measure how far we can correct this eyelid ptosis from this to this. Of course, this is our main outcome, but how about the other things like eyelash ptosis the patients are coming and complaining of? This could be an outcome. In my observation, people are complaining of that. Is it getting improved like this? And how many and how? We don't know. How about the associated lower eyelid scleral show, as you see in here? Some people are coming and complaining of that. Is it getting improved? How far and how? We don't know. That could be like this, getting improved completely or not. And the last but not the least is how we have the levator function changed post-operatively. And how can be this one implemented in our clinical practice of redo procedures. That's why the outcomes, to me, they are divided into primary and overlooked secondary outcome, including eyelash ptosis, lower eyelid scleral show, as well as the levator function check. We did a study on these overlooked outcomes. Here I'm going to present two of them, I mean the eyelash ptosis and lower eyelid scleral show, comparing the unilateral simple myogenic ptosis with unilateral aponeurotic ptosis, serving the other normal eye as a control group. All of those three studies have been recently published, and you can have access on PubMed or anywhere else. We graded the eyelash ptosis from 0, which is normal, to 3, the most severe one, based on Malik's classification. An associated scleral show was shown in our study as MRD2. We found preoperatively 50% of patients with myogenic ptosis. We had 58 cases in this group and 20 cases in the aponeurotic group. 50% of them had the grade 2 or 3, the moderate and severe type of eyelash ptosis, whereas 25% of aponeurotic group showed the same severity of eyelash ptosis, meaning that myogenic ptosis group are having more severe and more frequent ptosis, eyelash ptosis, than the aponeurotic group. When we did a correlation study, the lower levator function and more severe ptosis were significantly correlated with more severe eyelash ptosis. The eyelash ptosis got improved by 1 grade or more in more than 80% of both groups. However, more than 50% of the myogenic and 30% of the aponeurotic group remained with some degree of eyelash ptosis post-operatively. How about the scleral show? As you see here, the myogenic ptosis showed less severe in terms of mean scleral show comparing the ptotic side to the fellow eye. The myogenic group showed less severe than the aponeurotic with 0.8 millimeter scleral show preoperatively, and less frequent, 60% of the myogenic, whereas 80% of the aponeurotic group were showing the scleral show preoperatively. And post-operatively, similarly, the myogenic group ended up with less, remained basically a scleral show in just almost 9% of their cases, whereas 20% of aponeurotic group ended up with residual scleral show. The success of lower eyelid retraction or a scleral show after ptosis surgery, if it is defined of getting improved by 0.1 millimeter and more, was more than 90% in both groups. Here are some examples. Lash ptosis of 3 getting corrected to 0 after levator resection, and a scleral show of 7 getting improved 1 millimeter to be closer, but still remain the scleral show on the ptosis side. This case, however, is having lash ptosis of 3 totally improved, as well as a scleral show as compared to this one, 4-5, now becoming 4-4 in both groups, both eyelids. Lash ptosis of 1 is getting improved to 0, and MRD2 of 7 is getting 5.5, which is almost the same as the other eye. Lash ptosis, there is nothing preoperatively, remain the same. MRD2, however, getting 1 millimeter improved to somehow reach to the same as the normal side. And lastly, lash ptosis of 1 getting same post-operatively. MRD2, however, getting improved by 1.5 millimeter. Here we see the difference. Here we see no difference between the two eyelids. In conclusion, Myogenic ptosis, when we are dealing with that, they have more severe and more frequent eyelash ptosis. That should be considered than aponeurotic ptosis, pre and post-operatively, residual one, I mean. On the other hand, aponeurotic ptosis showed more severe and frequent lower eyelid scleral show than myogenic pre and post-operatively. We have 50% of myogenic and 30% of aponeurotic group remaining with some degree of eyelash ptosis, and 9% of myogenic, whereas 20% of aponeurotic are remaining with some degree of scleral show. How could those be implemented into our practice? Whenever we see a patient with a ptosis and higher grades or more severe grades of eyelash ptosis, we might consider beyond the levator resection to go for either tighter and deeper crease formation, anterior lamellar reposition, or gray line split to decrease the severity and frequency of remaining eyelash ptosis postoperatively. And we need to remember answering the question, usually coming from the patient, how about my lower lid scleral show? The answer is you don't need any lower eyelid surgery before the levator surgery is done, because most of these scleral show is getting improved. Any remaining one could be addressed later on. And thank you very much for your attention.
Thank you, Savri. As it turns out, we do have exactly 1 minute for that question of yours.
No, it's okay. You wrap it up. It's
No,
fine.
we do. I mean, I have nothing. I would have wrapped it up now.
This is for you and Rush. I mean, for everybody. So we saw a 55-year-old man with a severe unilateral ptosis with absolutely no extraocular movement restriction. And it was about a day old. So did the routine. I said, okay, it could be, let's do an MRI, and even thought of myasthenia and did everything. And all of it came negative. And basically we couldn't come out with anything, not a diabetic. So it was so strange because it was only a severe, complete ptosis with absolutely no involvement of third nerve anyway. I made even Ashwin, who's a neuro-ophthalmologist, check, no restriction of movements. We couldn't figure out. We said, okay, should we start steroids? And after 3-4 days, I don't know why we insisted. On the 5th day, we repeated ACRAM again. And it came very high positive from the same lab.
What did you repeat?
Acetylcholine receptor antibodies. So is there like a lag when the patient presents so acutely that there is a gap when you may get it negative? I mean, both of you and Akshay also studied it quite intently. So
yeah, so I'm not really aware, or I don't think I can give a date to say that, in acute phase, how much time it will take. I would assume, logically speaking, that if it's an autoimmune reaction which has a clinical manifestation, that has happened because already the antibodies are there. So you probably would have picked it up because it has come as a presentation. It's not, that's what I would say, but I don't know what Akshay has to say.
Yeah, I think it probably is. I'm going to put it to lab issues. It's unlikely that in a day you would get.
Fifth day we did.
5th day, yeah. No, I don't know. It's the only
because
thing.
The neurologist was pretty sure that it's myasthenia.
Yeah. So the only thing it could be that did the patient have a thymoma? Because if there's a thymoma that is actively secreting antibodies, then you could have that.
So he's scheduled for a CT chest.
Yeah.
That sounds
good. Before Tanvi tells us, I'd like to thank my co-instructors for being the last session on the last day of AIOS and wrapping up on time at 7:55. Thank you, everybody. And
thank you so much, our honorary
chairperson
and every speaker. Thank you so much for being the part of AIOC. We wrap up with the session for today. And it is the last session of AIOC 2021. Thank you so much for being the part of this family.
Thank you. I thoroughly enjoyed the videos, cases, and the presentations. Really, really good session.
Yeah, brilliant. Akshay, congratulations.
Bye-bye. Thank you.
Thank you so much. We conclude with this call for today. Thank you so much. Have a nice day ahead. Bye-bye.
Bye, guys.